let's talk about your face, right? And facial bones. And everybody's face is different, but we all have the same bones underneath, right? I just want to put different faces up there so it kind of makes it nice. Beyonce just canceled her by the way. Okay. All right, so facial bones. How many bones do we have on the face? 14 different bones in this little face. Oh my God. Why is it so important to image facial bones properly? And why is it so hard sometimes to do that? What's so special about facial bones? Irregularly shaped. That's a fair statement. What else?
Well, not everyone's head is the same.
Hmm?
Not everyone's head is the same.
Well, our bones are kind of the same. Huh? Range of motion. So depending on what kind of patient you have, you may not be able to get them to pose for you the way you want them to, right? All those skull x-rays and the SMVs, who can turn their head all the way up, right? So yeah, that's another one. But the main thing is it's their irregular shape, is that some of them are very small, some of them are very big, and they don't all have the same shape and the same location, and sometimes it's hard. In fact, yesterday I had an X-ray, ER X-ray of mandibles, and I had not done mandibles for a long time. So I was getting ready and trying to make sure that I have everything ready, and then all of a sudden they changed it to CT. So lucky me, right? But I was looking forward to do that, really, the mandible, because I hadn't done one. And sometimes it's hard to get the mandibles done, and you have to angle it and angle the patient and all that stuff. But we don't do enough of them, I think, in X-ray anymore. Most of them are done in CT. And because of the different shapes and the different sizes of the facial bones, you need to have very thin slices in CT to be able to cover everything. Can you imagine if you had a very small fracture right here and you won't be able to see it on a CT if you're doing 10 millimeter slices, right? Because you may just miss it. That's why when they do sinuses and facial bones, they do very thin slices, sometimes 1 millimeter slices. It takes a long time sometimes, and reconstruction of it takes a long time too, but it's worth it. I think the radiologists like it, and everybody else gets, the patient obviously gets advantage of it. Okay, so there are 14 bones. Some of them are paired, as you can see, right? So you have the nasal bones, the two nasal bones, two lacrimal bones, two maxilla, two zygoma, two concave, nasal concaves, one vomer, one mandible, right? And the mandible is the biggest bone of the facial bones. Which one do you think is the largest one that's not movable? Maxilla, correct. So maxilla and mandible are the largest ones. Maxilla is immovable, and mandible you can move. All right. In AP, you have a lateral. Sometimes the lateral or the sagittal view shows a lot more. Like you can see the lacrimal bone better. You've got the nasal bone. What kind of x-rays do you do for nasal bones? Both laterals and waters. So what do you do waters for? Why do you need to have waters? Nasal bone looks nice like this. Right, if it is deviated, right? If there's a fracture and it's deviated, you'll be able to see it on a waters and not a lateral necessarily. Okay. What kind of technique do you use for a lateral nasal bone? Finger technique, exactly. That's us old techs say finger technique. But you guys put it on AEC, right? No, don't do AEC. Always technique it, just like a finger technique. You'll always get it. If you center it right, you always get it in a finger technique. We used to do it on an extremity cassette. I don't know if you guys ever did it or not. On extremity cassette, how you would do fingers, we would do it on that. It'll come out really beautiful. Okay. More sagittal view, this is just on orbits, again, and facial bones, looking at it better. Now, if I wanted to do orbits, what kind of x-ray would I do? Not CT, x-ray. Caldwell, Reese, right? Reese for the orbitals. That's another hard one that I could never get it right. Almost never get it right. But
That's the 3-point contact, right?
that's the 3-point contact.
I tried to do it, but then at the end ended up going to CT.
Yeah. It's hard to catch it. It's hard to get that one area. Okay. More 3D reconstruction of the facial bones. Again, these come out really handy when they try to find out where's the fracture and where do they have to concentrate on. It's really good for the radiologists. Here's another familiar one, a coronal one. They're probably doing this for the sinuses. References are on the right side, so you'll see, you can see the frontal, basically the frontal face right there with the maxillary sinuses. A coronal view, right? How about this one? Right, this is an axial, and why can't I see the maxillary sinuses? Is it below or above maxillary sinus? Below maxillary sinus, right? So you're actually looking, right? So you have, this is another good thing about having these references. You see that's where your slice came from, and it's below maxillary sinuses. It's right above your teeth, actually, which is the palatine, right? What do you call that one? Heart palate. Thank you very much. It's right above heart palate. That's where you're looking at. You'll see. You may be able to see some ethmoid sinuses, not much. Definitely below maxillary sinus. So practice these images and see where your slice is from. Now here's my reference. Now, am I above or below maxillary sinuses? I'm in it, right? I'm in the middle of maxillary sinuses. That's why we can see them right there. Maxillary sinuses. Why can't I see frontal sinuses? Way below. Frontal sinuses are right here, so I'm way below frontal sinus. Same thing with the sphenoid. Can I see the sphenoid sinuses on this one? Shouldn't be able to. I'm below sphenoid sinuses. This is sphenoid. I can see ethmoid, I can see maxillary. I can't see the other sinuses though. Okay. Yeah. Well, the ethmoid sinuses are right around here. Yeah. Nasal septum, right? So the nasal septum, and then the ethmoid sinuses are here. I should point them here, right? Okay, so we're going more superior, right? Superior, now we're looking at the maxillary sinus, and you'll see the sphenoid sinus, and actually see ethmoid sinuses too. So all three of them you can kind of see, and this is an axial image, right? Sphenoid is always posterior. Sphenoid sinus is always posterior because remember it's in the middle of the brain, right? It's in the when you look at it on a lateral image, it's always posterior. So that's why when you're looking at it on an axial view, that's anterior, this is posterior. You always see the sphenoid sinus on the posterior side. Question, Rohit?
Yeah, can you see the maxillary sinuses on this one?
Not really. I know we passed through them, but you really can't see the maxillary sinuses. If you're looking at it like this, you're above them. But this one kind of shows you're in the middle. So maybe the slice is a little bit off on this one. It should be right above, right here, not necessarily in the middle. I can't see the maxillary sinus on this one.
But there is a projection where you can see through it.
Yes. There should be. It's probably in your book. Actually see cord. Okay. Thank you. All right. Here's another one. This is obviously a picture, it's not an X-ray image or CT, but it shows kind of where the nasal septum and the nasal meatus is, which is really important to know. As far as the frontal sinuses, right, that's the frontal sinus, you've got the sphenoid sinus in the back, and all of this is ethmoid sinus and nasal meatus. It's important to know because that's where, when we talk about sinuses and possible fluid in the sinuses, that's how all the fluid gets out of the nasal bone, the nasal area, and it goes out into the throat. So it's good to know these passages and know them, like middle nasal meatus, inferior nasal meatus, and then what's the difference between meatus and a concave? You see the difference? Meatus is the passage. Concave is actually the bone. Okay? So you always have inferior nasal meatus, and then you have the inferior nasal concave over there. Here's the middle nasal concave, and then superior nasal concave. All right. We're gonna get into sinuses in just a second. Why we have them? Yeah.
They talk about turbinates. Are the turbinates another word for one of those, or something completely separate?
Turbinates. I don't know.
I had it in my book, and I don't remember where I
This
saw it.
book?
I think it was that book. I don't remember what page it was on, but I remember seeing turbinates. And I always get confused with the turbinates.
Yeah, I would too. I'll double check. I don't know if this book mentions turbinus or not, but if you see it, let me know. And I'll double check. I don't know. Same area, it's showing it on a CT. So we looked at it as a sketch, as a drawing, but now we can see the exact same thing in a CT, where you can see all the cavities, all the meatus, everything, all the bones that are there, and you can tell, you can appreciate the way CT can actually show you all of these details in the bones. As we probably can't do this on a regular X-ray. CT is the one that does it. So very important. It's a really good tool to look at the facial bones. That's what's inside them. And the mandible, I'm not going to talk about mandible. You guys know the different parts of the mandible. You know how it works. All of. Let's go into sinuses just for a second. Why do we have sinuses anyways? They're always giving us trouble. They're always full of fluid. We get infected. Why do we have sinuses? Resonating the sounds, right? Okay, so that's one reason to have sinuses, resonance of the sound. What else?
It helps with the pressure also in the head.
Put the pressure on the head, or
No, relieve the pressure.
relieve the pressure from the head. How?
I don't recall exactly, but throughout the day we actually have different pressures in the head, and it actually helps relieve the pressure. So I don't know if it's part of this.
Maybe what you're saying is that it relieves a lot of the weight from the skull, because think about all the bones that are in your skull, in your head, and how heavy your head can be without having some air inside of it. So it does actually relieve, the sinuses do relieve the pressure of the weight of the skull that way. And it's a passage, again, for draining all the liquid and the fluid that's inside the head. And there are passages that can drain that. So those are the things about sinuses. Those are the two reasons to have them. Resonating the sound or your voice, and also keeping the skull light. I mentioned a little bit as far as development of the sinuses. So some of them won't develop until you're 17, 18. In fact, the frontal sinuses develop kind of late. That's why when you do those child sinus x-rays, you probably won't see frontal sinuses. Maxillary develops first, and then it goes on and on with the sphenoid, ethmoid, and then the frontal. Okay. So here are where the sinuses are. It's just a picture of them. You'll see them. You've seen them on CTs. What else? Go there. We talked about the two reasons for having sinuses. We don't have to go through them. Again, some axial images. This one still doesn't have the frontal. It doesn't show the frontal as good. So let's look at this one. Sagittal, right? It looks a little bit different though. Is it a CT image? It's an MRI. It's an MRI image, and it's so fantastic in looking at the small little structures, and it's not just looking at the bones anymore. It's looking at soft tissue. A lot of the things that we couldn't see in CT, we can actually see in MRI, and it's. I love MR images. They're really fantastic. Let's see. Going back to CT again, looking at a coronal image, obviously looking at the sinuses. And we already mentioned when we do CT sinuses, they have to do very thin slices to be able to see all this detail. Otherwise, they'll miss it. Now, why do you think, for those of you who've done maybe sinus CT when you did your CT rotation, why do you think they do bone windows and soft tissue windows? Jill?
They're looking for fractures and also the fluid, so you need to be able to see both.
Right. So bone windows will show you the fractures. What about if they come in with just sinusitis? There is no fracture. They don't think there's a fracture. There's no trauma. Why would they still do bone windows?
See the growth of the sinuses within the bone. See placement.
Growth. Okay, so that you're getting close. So think about chronic sinusitis. What happens in chronic sinusitis? Yeah, exactly. So the infection is chronic, means it's taken a long time, right? It's been there a long time. So if you have chronic sinusitis, it can actually affect your bones around the sinuses. It could affect your facial bones. It could affect your cranial bones. That's why they need to see the bone to see if there's anything wrong with the bones, osteomyelitis, anything like that. I had a friend who had chronic sinusitis, and she ended up having a surgery. She actually went to the ENT, special ENT at Cedars-Sinai. They took all the mucus out of her sinuses, and the surgeon was telling her it was like taking Play-Doh out of your nose. It was that bad, the mucus and everything. That was chronic, and she was always plugged up, summer, winter, anytime. She couldn't breathe, she couldn't do anything, so.
It can actually cause blindness.
Probably blindness. I mean, think about all the nerves that are there. It could affect all the nerves there, so. It's a very serious thing. That's why they do the bone windows, to look and see if there's any kind of effect on the bones, so they can somehow treat it. So, sinusitis. So this is an important image, just so for you to note. We call this osteomeatal complex. Okay. And I want to make sure it's page 74, osteomeatal unit or osteomeatal complex. So this is where you can see where ethmoid and maxillary sinuses are connected with each other. And you're looking at the ethmoid sinus on the top, right? And you'll see most of the time sinuses are connected with each other with those pathways. Why are they connected? Drainage, right. Mostly because of the drainage, they have to be connected. So if you have the ethmoid sinus, a little bit lower or more inferior to it, you'll see the ethmoid bulla. And then all these connections that are from the ethmoid all the way to the maxillary sinuses. Those are important to know. Later on, on a question, I might ask you and say, well, where is, for example, infundibulum? Infundibulum is just a very thin pathway that's between the ethmoid sinuses and the maxillary sinus. Later on, when we talk about brain, there's actually infundibulum inside the brain too. So here for the sinuses, just know that it's a very small passage between the ethmoid and the maxillary sinus. And that's one of the major parts of the osteomeatal complex, infundibulum. And then you'll see this is one of the processes of the ethmoid bone. That's an uncinate process of the ethmoid bone. The rest is just bones. And then you come here, you'll see the nasal conchae again. The ones that we looked at on a sagittal image, you're actually looking at it on a coronal image here. So this is important to know. Same, you're looking at it on a CT this time. It's another coronal view. You're looking at the osteomeatal complex with all those passageways. Questions so far before we get into orbit? Next is orbit. So here's another 3D CT image. Reconstruction image of the maxillary bones. This is where they want to look and see, okay, this guy got hit, boxer's fracture or whatever. They boxed into the eye and something's going on with his eye. So we want to know where, blowout, thank you, blowout fracture, not boxers. Boxers is here. Blowout fracture, but they were boxed somehow, right? Somebody hit them in the eye, they get a blowout fracture. Where's the fracture? To know that, and that's why they do all these CTs. This is a repeat of the same slide you saw. This one too, you'll see a lot of them. The reason I'm showing you this now, we're concentrating on the lens of the eye. You won't be able to see it on CT as much, but on an MR it looks a lot better. You'll see the soft tissue and actually the nerve, the optical nerve that goes back. So we'll look at one. That's kind of a picture of the eye. You need to know this. You need to know it on a CT, on something like this as a picture, and also on an MRI, which we'll look at next. The eye obviously has the lens anteriorly, then you've got the posterior compartment of the eye, and then all the way when you look at the posterior portion of the lens, you'll see all these tracks going back. So this is what the optical canal is, which has the optical nerve inside of it. So you'll see the canal and the nerve inside, and then the optical nerve goes way in the back of the head, and then into the occipital bone, which we'll talk about later. There are certain muscles that are important around the eye that actually move the eye, move the eyelids. Those are important. And when we go to one, you can see them better. So this is a CT again, but you're looking at the globe of the eye, and then here's the optical canal going back. Let's look at this one. Shows this. Let's look at some of the MRs. So this is an axial MR going through the eyes, sort of on the superior portion of the eye. Again, going back. Looking at nerves. We'll get into a good MR picture, but just looking at it, these are the muscles that you need to know. There are two kinds of muscles in the eye. The rectus muscles, which you'll see over here, you have the superior rectus muscle, you'll have an inferior rectus muscle, right? Both of them actually have to do with the movement of the eye. And then you have the oblique muscles. You have an inferior oblique, and you also have a superior oblique muscle. They don't show the superior. What else is important in this picture?
What are the oblique muscles do?
I'm sorry?
The oblique muscles, what are they?
I'm going to show you the oblique muscle. They also move the eye. They're also moving. They all somehow move the eye, both the rectus muscles and the oblique muscles. Let me go to the next one. I'm looking at the picture. This one's a good one. Here's an MRI picture. It's a sagittal picture looking through the eye, right? So you're looking at the inferior rectus muscle, and then you've got the superior rectus muscle. SRM is superior rectus muscle. Here's the inferior. And what's in the middle? Optic nerve. If you say optic canal, that's okay too, because really you can't tell whether it's a canal or is it the nerve that's going there. So both are fine, unless it shows it really well where the nerve is. I won't ask you to distinguish between the two. On this picture, you can say optic canal or optic nerve. So here's a CT of the same area again. It's a coronal, and it's funny because now the anterior and posterior rectus muscles are not shown. They're up here, right? And then the superior oblique muscle and then the medial rectus muscle are kind of shown here. So the rectus muscles, remember, you have a superior and inferior, you have a lateral, and then you have a medial rectus muscle. Lateral just meaning on the lateral side of the eye, and then here's the medial rectus muscles. So those are the four, and then you've got the two oblique muscles. Questions? The best picture to look at with all the muscles is probably the page 83 that says muscles of the eye. It shows the inferior oblique. It shows superior rectus muscle, inferior rectus muscle, and then there's one more muscle up there that's called superior levator palpebrae muscle, which is the muscle that actually moves the eyelid. And that's important.
Can you tell the difference between the levator muscle and the superior rectus muscle on the CT?
No, not on the CT.
So if you were to put either one, is that okay? Or
I won't have you do it on a CT. I'll probably have you show it to you on an MR where it shows really well, and on a sagittal image. So you'll be able to. That way you'll be able to. So if you're looking at page 83, the top is just the picture, and then the bottom shows the MRI image of the same area, which shows it really well. Both the rectus muscles and then the superior palpebrae muscle. Okay, what's another good one? I think that's it. Those are the good pictures to see. All right, let's see. Which one? So I think we already kind of mentioned this. The four most popular skull or facial bone x-rays or CT procedures that you've seen or you've heard of. So let's talk about most popular bone x-rays, skull or facial bone x-rays. What are the most popular ones? Waters, Caldwell, lateral.
For CT, you see a lot of temporal bone.
For x-ray, let's talk about x-ray first. So lateral, Caldwell, I heard lateral, Caldwell, Waters. Axiolateral, you mean the SMV or the mandible axiolateral? Towns, I don't know. I haven't seen Towns for a long time. You do Towns? You guys do Towns? Yeah, we don't do skull X-rays as much anymore. So we'll say axials or Towns are good. How about CT? So what do we do for CT when we want to do CT head? What else? Facial bones, for facial bones. IACs, right? What else? CT sinuses, those are popular. That's probably it. Have you guys heard of anything else?
IACs and temporal bones are basically the same thing.
Yes,
It's open and
correct. And also IACs and MR too, but we're talking about CT right now. I'm not gonna have you draw today. We've had enough group discussions today. Any questions? And we're done.